So our next speaker is Dr. S. Lakshmi, MS Lakshmi. The title is Refractive Outcome of Ciliary Sulcus Implanted Intraocular Lenses.
Good evening, everyone. There is nil financial support and sponsorship. Introduction. Cataract surgery is the most commonly performed surgical procedure in ophthalmology, and posterior capsular rent is a common, potentially sight-threatening intraoperative complication with an incidence of 0.2 to 14%. Even though advanced techniques, instrumentation, and technology has reduced the rate to 0.45 to 5.2%, and in experienced hands it is reduced 0.45 to 3.6%. Optimal location for IOL implantation after successful cataract extraction is within the capsular bag, closer to the nodal point with great stability and resulting in a better image resolution. The placement of IOL in the ciliary sulcus is preferred in case of PCR, zonal laxity, lens subluxation, or planned piggyback intraocular lenses. So sulcus implanted IOL has a more anterior effective lens position, showing a myopic shift from the preoperative predicted value, producing a suboptimal visual outcome in some patients. So generally surgeons empirically subtract 0.5 to 1.5 diopter from the IOL power calculated before surgery. So the primary objective was to determine the difference in the preoperative predicted and postoperative spherical equivalent refractive shift, and to determine the difference in the IOL power for in the bag implantation and the ciliary sulcus implantation, and to assess the intraoperative and postoperative complications. So this prospective interventional study was conducted on 77 patients fulfilling the inclusion criteria in the Department of Ophthalmology, Al Jalpa Hospital and Research Center, Kola, Karnataka, from September 2022 to December 2023, after obtaining approval from Institutional Ethics Committee and CTRI and written informed consent from the subjects. Inclusion criteria was all cataract patients of either sex more than 40 years of age with capsular rupture, whether it's anterior capsular tear without extension, anterior tear extending to posterior capsule, and posterior capsular tear with intact anterior capsule, zonular dehiscence, weak zonules in case of pseudoexfoliation, uveitis, or traumatic subluxation of lens. Patients with these patients were excluded, that is lack of anterior capsular support, patients on any topical anti-glaucoma drugs, patients with lacrimal gland and drainage disorder, history of any ocular surface surgery, ocular trauma, and thyroid disease patients. So after obtaining demographic data, each patient underwent the standard protocol for cataract evaluation and surgery. Once PCR was noted, the lens capsule bag was assessed, and in patients with sufficient anterior capsular support, IOL was implanted in sulcus after reducing 0.5 to 1 diopter from the power calculated by the SRK2 formula for in the bag IOL implantation. And data was entered into MS Excel data sheet and analyzed using SPS22 and paired t-test is a test of significance. So the results were there was 20 males and 56 females. Mean age in years was 63.50. Mean axial length was 22.51. Mean planned IOL power was 22.04, and mean sulcus implanted IOL power was 21.50. The pre-predicted spherical equivalent refraction mean was found to be 0.0108. Postoperative spherical equivalent refraction was mean was 0.0586, and p-value was found to be less than 0.001, which was statistically significant. The virtual IOL power was in mean was 21.50, and the sulcus implanted power was 22.046, and the p-value was found to be 0.001, which was found to be statistically significant. And this graph shows the cumulative distribution of spherical equivalent refraction after IOL implantation in the sulcus. The preoperative mean the pre-op visual acuity mean was found to be 1.039, and post-op visual acuity was found mean was found to be 0.346, and standard deviation 0.269. Post-op 1 week visual acuity was the mean was 0.246 and standard deviation was 0.194, and post-op 1 month was 0.189, and p-value was found to be 0.001, which was found to be statistically significant. Seeing the logmar post-op visual acuity, that is almost 74 patients had good outcome. Only 3 patients had was in the range of borderline outcome in post-op patients, and no post-op patients had poor outcome. And p-value was found to be 0.001, which was statistically significant. 38 patients in the stage in which PCR has occurred most commonly was during the cortical wash, that is 38 in 38 patients. followed by hydrodissection and nucleus prolapse. The complications, 11 patient has tried keratopathy, followed by endothelial pigment dusting and IOL pigment dusting, followed by iritis and CME, which was subsequently managed during the postoperative period. Most of the patients had good visual outcome, falling in the good outcome visual category of WHO classification. So during cataract surgery, placing the IOL in the ciliary sulcus requires decrease in the lens power, and this is due to the myopic shift of the optic that increases the effective power. So the greater the power, the greater the difference. Thank you.
About the choice of IOL, that should never be single piece. That's a very important, otherwise you could end up with a lot of uveitis and efficient syndrome and a lot of other things. So it is mandatory to look for the IOL, and you should have a backup of 3-piece IOL at any cost. Maybe you have to go no way out, even for very simple Indian lenses you may have to give a Alcon 3-piece lenses. That is very important. You have to save your skin as well as of the patient. Both are important.
Just one question. Was it a single surgeon study with a single type of IOL, or was it done by different surgeons?
It is done by different surgeons.
So, but the outcome was more or less the same in all the surgeons,
Yes, sir.
irrespective of it, and with a single type of IOL.
Single type of lens.
And in no case was the wound size increased.
No, sir.
Okay, thank you.
I noticed that one of the inclusion criteria was individuals who had an anterior capsular tear with intact posterior capsule. So you can place an IOL in the bag. Why was the IOL placed in the sulcus in that case, if the posterior capsule is intact?
Extending to the posterior capsules.
Extending. So the posterior capsule is not intact, that means.
Not in that. It was.
Okay. And also in the
extending to the posterior capsules.
extending to the posterior. Also, and also you mentioned that zonular laxity also you would prefer implanting a lens in the sulcus. I mean, I think most of us would prefer implanting it in the bag after stabilizing the bag with a capsular tension ring or any of these.